So if other people have questions along this, if other people have encountered situations or want to add to this, please feel free to join in. But this led me to do a little review anyway, and it's always a good opportunity to think about which medications are appropriate for people. So I don't have disclosures. I'm going to be talking about off-label uses of some medicines, from switching people from methadone to buprenorphine. The number one thing to be aware of, as what we talked about with this case, is why does the person want to transfer? For me, it's very clear that it should be patient-initiated, or in this case, medically appropriate and indicated. If the person is stable on methadone, there does not seem to be any reason that I can see other than patient preference, or in this case, like distance or medical pieces. It does not make sense to transfer them to buprenorphine if they are stable with their treatment plan, because the process is not straightforward. It is easier to go from buprenorphine to methadone than methadone to buprenorphine, and it's because of the pharmacology of the two medications. So buprenorphine is the partial agonist, and also has a high affinity for the mu receptor, along with the slow association and dissociation, which is good and bad. If you're trying to get somebody from methadone to buprenorphine, it can knock off the methadone and precipitate withdrawal for a long time, because the methadone is still the full agonist, and so that makes it challenging to do the induction properly, which is why we're talking about how to proceed carefully with this. So because of these properties, we do need to proceed with caution. There can be benefits of transferring to buprenorphine. Lower risk of overdose is what we like about it, than as with this gentleman. Lower risk of respiratory suppression and the QT prolongation. Seem to be fewer medication interactions and less severe withdrawal if the dose is missed. So these are all things that people like about buprenorphine from a pharmacologic standpoint. Lifestyle factors, because of that Data 2000 waiver, make it possible to be easier for people to just have access to, like this fellow here driving an hour each way to get the methadone from a daily dosing clinic versus being able to have a week supply, and you can pick it up at a local pharmacy versus going to a specific clinic. So there can be patient factors as well. So why would people want to switch? Some of these are fairly well cited by both patients and literature in terms of the stigma of going to a daily dosing program, the distance to get there. Sometimes I've heard people talk about there's dealing going on in the parking lots, and they just feel like their recovery is more challenged by going there. If they've gotten jobs and need to travel, or just for leisure, it's harder to do that. If you're needing to go every day to a clinic, they're sometimes just unhappy with the structure of the program and the rules that go along with it. Other times there can be ongoing use of other substances that make it challenging for them to continue at the OTP, or would make it challenging for treatment to be successful in the outpatient setting. So both of those factors need to be considered. When a person comes to me with this request, I always try to get the records from the OTP, especially if there's still patients there, to try to coordinate that care. We always make the phone call. Sometimes it's challenging logistic-wise. If the clinic is closed at 11:30 or 12 and they're not answering the phone, how do we do that? There are some barriers sort of systemically built into that process, but persistence is the key. And if somebody is going to want this, knowing it's not going to be an immediate process anyway, allows you to slow down and spend the time getting those records. You want to verify the dose, verify the treatment history, make sure that what they're saying and what the records show there are consistent, and make sure that you're going to be able to coordinate the care, because they need to really help you and help the person reduce the dose and taper down to an appropriate level before making that transition. So in the past, tip 40 was what everybody was using as their source, and they said they wanted people to taper methadone to 30 milligrams per day for at least a week, and then hold the methadone and all other opioids for this 36 to 72 hours as long as possible. Once COWS is greater than 13, so having very obvious signs of opioid withdrawal, to be able to then induct a person on buprenorphine 2 to 4 milligrams, and then continue with the usual induction, waiting an hour or 2 hours before continuing on. And knowing that because of the longer half-life of methadone, that it can take higher doses of buprenorphine, up to 32 milligrams initially, and just really dosing based on patient comfort. So not guessing that, hey, we know 16 milligrams opioid receptors are 90% saturated, so therefore we're going to stop at 16, doesn't make a lot of sense in the first couple days, because it's it still needs to have occupancy of the existing receptors, and the person's pretty uncomfortable and in withdrawal. So it's, tip 40 is okay to say go ahead and go on up, and then you can reduce later as needed to a more appropriate maintenance dose. But the challenges with doing it this way is just not straightforward physically, was what we were just talking about. In this case, really the opioid withdrawal with higher doses of methadone, very, very challenging. And after a couple of days, most people are showing fairly significant withdrawal, and that puts them at huge risk of relapse during the methadone taper. So in our setting, we often use the comfort medications, clonidine, dicyclamine, NSAIDs, hydroxyzine, tizanidine. I've used ropinirole for restless legs, really just looking at it as symptomatic relief based on whatever they're telling me, not necessarily what I think they need. I stay away from the benzos. Some places have, if an inpatient setting, perhaps anxiolytics, sedatives may be okay to use. I stay away from, on an outpatient basis, giving people the benzodiazepines just from the increased risk. If they do relapse, then the respiratory suppression risk is even higher. So the point of all of that is that it's a very sort of dangerous critical window, and people have sometimes relapsed and not survived this process. And so what you want to do is make sure you minimize that risk during this transfer. In this particular fellow's case, he was inpatient, so it was pretty safe. But if you're doing this in an outpatient process, having close follow-up and making sure that you're staying in frequent contact and providing therapy and support, and again, that coordination with the OTP is really, really important. So came across an article recently. A couple of folks out in New Zealand and Australia are looking at trying to do this faster, because if there's a, at the OTP, there's federal guidelines of how slowly they suggest going down as well as increasing. So that can take, going from 80 to or 100 milligrams of methadone down to 30 can take months. And that's also a very, very challenging time to do it. So because that process is so drawn out, people are looking for better ways to do it, faster, easier. So if we can figure out the ranges, and this fellow Lynn Zaris and his group out of Australia, they have recently looked at amending these guidelines and come up with new protocols to address this transfer, and looking at low dose methadone, moderate dose methadone, and high dose methadone, and making those transfers and looking at these protocols and how people survived it. They found that really reducing it, if it's greater than 70 milligrams, best to do it inpatient, or if they have significant health comorbidities or psychiatric instability or unstable socially. But otherwise, they were able to successfully do this outpatient by reducing it until mild to moderate withdrawal between doses. So whatever, that sounds very vague, and it is very vague because it's very subjective in terms of what the person is evidencing, but as low as basically seems appropriate to get, and then waiting greater than 24 hours after the last methadone dose. Cows greater than 12, go ahead and start buprenorphine at 2 milligrams. And then they said monitor cows hourly, give 6 milligrams after an hour. So more than the usual induction of 2 and then 2 and then continuing, but 2 and then 6, and then 4 milligrams as needed if cows greater than 12, and keep on dosing at that level until the patient's comfortable using the same adjunctive medications I had described earlier for comfort. So they found fairly good success rates on the order of 80% adherence to their protocol by doing it this way. Patients seemed to tolerate that, and they didn't have people relapsing and or dropping out, and maintained that their outcome measure was, were they able to successfully transition to Suboxone or buprenorphine afterwards, and they were fairly successful with that. So they've got a couple of good articles, and I've got those references listed at the end of this if you want to read more about it. But this seems like a much quicker, but at the same time still considering safety, and that trying to minimize that window where people are at highest risk of relapse. So would I have done it this fast for this guy in the hospital? We could have, if everything, since he was at 75 milligrams, he would have fit this. So we could have waited until he was a day or two in the inpatient setting, and it would have been the most appropriate time to be able to induce him. Definitely within a week of that, by the time he was discharged, that would have worked as well. But fortunately, he made it to the outpatient setting, and we were able to get him going. But it's nice to know that we had options to transfer him with some evidence for this. It feels very much like a lot of this is up and coming research in the live setting and in situ studies, so to say. So we just run it by and see how people survive the process. It seems like they're doing pretty well with it. So I guess what I'll leave with is that there is no single right choice, methadone or buprenorphine. It really depends on the person, their situation, and their characteristics, and making sure people coordinate with the OTP, and of course supporting the person as they go through it, making sure you have really good follow-up in between, so that they know if there are any issues, they can always contact you and not leave the person hanging. Thank you very much. Any questions?